Hi, are you ready to learn about the evaluation and management coding guidelines? Yes, all have been waiting for this, and this the topmost request. This is Surya Johnson, your medical coding guide. Hi, in today's video we're going to discuss about the general E&M coding guidelines 2023. Why I'm mentioning it's 2023? Because there's a huge change in 2023 and I really like this change, especially for this evaluation and management section. I believe we have removed the burden from the shoulders of the coders and it's very easy. I think so, and I think it'll be easy for you all. So let's dive in. In today's video, we're going to see about the E&M coding guidelines 2023, the general guidelines. So as an overview of this E&M coding guidelines, the American Medical Association AMA has updated the CPT evaluation and management codes and guidelines. This is a huge update, like we've been following the 1995 and 1997 guidelines for so long years. These two have been removed to elaborate and considers the HPI and the examination part along with the medical decision making, right? So from 2023, these have made a major change. Why these changes are made? Because these changes are aimed at reducing the documentation and administrative difficulties. So the doctors and the administration teams don't have to worry a lot about the documentation, because it's all about the medical management of the patient. That considering those things, removing the burden from the doctors and the administrative perspective, and also I believe from the course perspective, things have been made easy. The main aim is not for coding. The main aim is to enhance the quality of the patient care. So the medical management is the key thing that doctors should be focusing, not on the documentation of all the things which is not relevant according to the doctor. It doesn't mean that all the documentation is not relevant. No, the documentation is the key. But reducing the burden of unnecessary documentation, focusing on the management of the patient's physical health, physical status is the key. Keeping on that, the AMA has revised these codes and guidelines. So this change are aimed at reducing documentation and administration difficulties. In my last video about the 2023 CPT changes in general, I have already discussed about the addition, deletion and revision of what codes have been added, deleted and revised in the CPT section of 2023. I have already explained in my previous video. If you have not seen that yet, I'll put that link in the description box below. You can go that and see there. So you will have a detailed idea about what are the E&M section that have these changes. In this video, I will not be covering those things. This is only for the guideline. There's a major revision, or you can say there is like a combination codes of hospital inpatient and observation care services E&M code 99221 to 99223 and 99231 to 99239, and guidelines have been changed. So hospital observation services E&M codes were deleted. Inpatient hospital services E&M codes were revised to include observation care services. So these all things I have discussed in my previous 2023 CPT code changes video. You can go and check those things. And there's also a changes to the prolonged service codes, which I have discussed in my earlier previous video. So coming to the evaluation and management, so the E&M guidelines are written for the following categories. So the entire guideline that I'm going to discuss in this video are written for the following categories: office or other outpatient services, hospital inpatient and observation care services, consultations, emergency department services, nursing facility services, home or residence services, prolonged service with or without direct patient contact on the date of an E&M service. So these categories imply the new E&M guideline. E&M guideline I'm going to discuss in today's video applies to all these categories. Before diving into the actual guidelines, please grab your notes, pens, and if you have 2023 CPT book, very well you can reference to that, and please take notes. So before getting into the E&M guidelines, first we will see about the E&M code format. So how is the code format? Why I'm telling about this code format? Because when you're going for the exam, or even when you're going for the work, you should know the formats of each codes. Then only it will be easy for you to look into those things, specific keywords, and choose that code. Otherwise you should be like randomly running through the same codes again and again, not knowing where to look for what. So you should know the E&M code format. So if you see this example code 99234, which is in hospital inpatient or observation care CPT. So the first will be the unique code number. So the code number is the code, CPT code. It will be unique. It will not be repeated for any other codes in the code book. So this is the unique code number. Second one, you should know the place or type of service. So where is this service occurring? What kind of service it is? So it is in a hospital, inpatient or observation care. So this is the type of service. You'll be checking into that. Third one is the content of the service. What kind of evaluation and management is done in this place or type of service? For example, in this scenario, it is for the evaluation and management of a patient, including admission and discharge on the same date, which requires a medically appropriate history and or examination and straightforward or low level of medical decision making. This tells you what kind of the patient encounter it is. So it is including an admission and discharge on the same date. So this kind of E&M it is. So which requires a medically appropriate HPI, an examination and a straightforward or low level of medical decision making. So this is the content of the service, what kind of service it is and what kind of medical decision making this code applies to. So the fourth one is the time specification. So when using total time on the date of the encounter for code selection of this 99234, 45 minutes must be met or exceeded. This is where the time is specified. So whenever you're choosing the code, if you're just choosing the place of type of service, you should know where to see which line to see. Like you cannot go and search in the last line for this type of service. You understand my point, right? So know the code format. This applies to all the chapters. All chapters have a different type of code format. In the future, if I'm covering the other surgery or other CPT code chapters, there I'll explain you the code format for all the chapters. Don't worry, I got you covered. So the next one, the evaluation management section. You should know who is a new patient and who is an established patient. So whenever a patient receives any professional service from the physician or another physician in the same group of specialty within the last 3 years, if the patient has already received any service, any professional service from that physician or the other physician in the same group of the same specialty within the 3 years, if they've already received, then it is an yes. So if it's an exact same specialty and subspecialty, then the patient will be an established patient. So the established patient is a patient who have been seen by the same physician or another physician from the same specialty and subspecialty within 3 years. That patient is called as an established patient. So who is a new patient? A patient who has not received any professional service from that physician or any other physician in that same group, in the same specialty and subspecialty. He has not seen any of those same specialty or the same group doctors within the last 3 years, then that patient is called as a new patient. So this is the decision tree for new versus established patients. So coming to the next question, initial versus subsequent, because some services has a difference of new and established, and some level of E&M codes like in the hospital, inpatient, like that, they have initial and subsequent. So you should know what are the difference. So what is an initial service? So an initial service is when the patient has not received any professional services from the physician or other qualified healthcare professional or another physician or other qualified healthcare professional of the same exact specialty and subspecialty who belongs to the same group practice during the inpatient observation or nursing facility admission and stay. So the patient has not received during that inpatient observation or nursing facility admission and stay, the patient has not received a service from that group of specialty or subspecialty physician. This is the first time the patient is taking the service from this professionals. So in that case, it becomes an initial service. So a subsequent service is the opposite. So when the patient has received a professional service from this group of physician or other healthcare or qualified healthcare professionals or another physician or other qualified healthcare professionals of the exact same specialty and subspecialty during the admission and stay. You got my point? So during the admission and stay only, not for 3 years. 3 years applies only for the new and established patient. This initial service and subsequent service applies to that admission and stay. So this initial and subsequent service. So this initial and subsequent service is a new definition, is a new updated thing in the CPT book. So you can just go through the description what they mean, and if you have any doubt you can put it in the comment section below. So what is the major change in this E&M guidelines? So the major change in the E&M guideline from 2023 is the level of E&M service that we are choosing, the codes, will be based on the following. Which one? The level of MDM as defined for each service, or the total time for the E&M service performed on the date of the encounter. Moving forward from 2023, how we will choose the level of E&M services from the books? It's based on the MDM. If you're going for the MDM, then it is only MDM. Based on the medical decision making, you will choose the service. Otherwise, if you're not choosing the medical decision making MDM, if you're going for the time, it should be the total time for the E&M service performed on the date of encounter. So the total time means time spent by the practitioner, that is the doctor or physician, includes a face-to-face and non-face-to-face time also. Moving forward, history and examination part will not be used, is no longer used to select the level of code. There will be history or exam. It doesn't mean that there should not be any history or exam in the patient documentation, in the patient medical record. There can be a history and examination, but from the coding perspective, that will not be considered or that will not be calculated to select the level of code. So the level of code will always be based on the MDM or the total time of the encounter. So this is the major and huge change which I really like. So what happens to the history and examination? So coding is no longer based on the history of present illness HPI, review of systems, ROS, or physical examination PE items documented. So we will not base the selection of the E&M level codes based on these things. So it is recommended that physicians and other healthcare professionals document what is necessary and helpful for the care of the patient and for the colleagues reviewing the medical record. Physicians and the other healthcare professionals, it is a recommendation that they will document, but it's not a mandatory, like they should, it's not mandatory they should go up to this kind of level, this detailed level of documentation. The documentation can be there which is necessary and which will be helpful for the patient's care by them or by other physicians when they are reviewing the medical record. There is no purpose related to coding. Likewise, as I already told, so the level of MDM as defined for each service or the total time for E&M service performed on the date of encounter will be the appropriate thing, will be the appropriate selection to choose the level of E&M. So in today's video, we will be discussing in detail about MDM and about the time. So how you can understand the medical decision making from the documentation to choose the level of E&M, and how time can be calculated, and what are the key things to look into while choosing the level of E&M based on these two things. Let's dive in. So the medical decision making, the MDM guideline, is separated into three categories. Number one, the number and complexity of the problems addressed during the encounter. Number two, the amount and or complexity of data to be reviewed and analyzed. Number three, the risk of complications, morbidity and or mortality of patient management. So now for the first one, number and complexity of problems. Second is the data. Third is the risk. So that is the easiest way you can remember. So these three comprise the MDM, medical decision making. This problem complexity, risk and data, in this 2 out of 3 elements are met, so you can choose that level of E&M code. So we will see the MDM table here. So the MDM, there are 4 types of MDM, medical decision making: straightforward, low, moderate and high. So in this, the first component, problem complexity. The problem complexity has 2 types. It is the number of problems addressed and severity of each illness addressed. So number of problems addressed and severity of each illness addressed. So in this table, if you can see, the straightforward MDM requires a minimal number and complexity of problem address. What criteria goes to a minimal? Minimal will go for one self-limited or minor problem. Only the patient has one self-limited or minor problem, the patient problem complexity will be minimal. So if the patient has 2 or more self-limited or minor problems, or one stable chronic illness, or one stable acute illness, or one uncomplicated illness or injury, one acute uncomplicated illness or injury requiring hospital inpatient observation level of care will be eligible for a low number and complexity of problems addressed. For a moderate, if you can see in the table, one or more chronic illness with exacerbation, one or more chronic illness with exacerbation, progression or side effect from treatment, two or more stable chronic illnesses, one undiagnosed new problem with uncertain prognosis, one acute illness with systemic symptoms, one acute complicated injury. Any one of these is met, then it becomes a moderate number and problem complexity. So, for a high number and complexity of problem addressed, it can be one or more chronic illness with severe exacerbation, progression or side effect or treatment, one acute or chronic illness or injury that poses a threat to life or bodily function. So, how it is going? It is going from self-limited or a minor problem to more than one self-limited or minor problem will become a low level, and mild, acute, stable illness, stable injuries and complicated illness will become a low, and moderate is going for one or more chronic illness with exacerbation, side effects, and two or more stable chronic illness, and a new problem with uncertain prognosis, and also an acute illness with systemic symptoms. Whenever the severity of the patient problems increases, it goes to the next level. So this data, as you can see, there are three types like test, records, historians, and then the second one is the independent interpretation, third is the discussion of test. So these three comprise the data. When looking into the amount and or complexity of data to be reviewed and analyzed under MDM, we have straightforward, low, moderate and high. The physician has not reviewed or analyzed any amount of data or has analyzed only a minimal amount of data, then it goes to the straightforward. It is very straightforward. So from the low to moderate, high, they have these categories. The categories are based on the three items that we discussed for the MDM data, right? Test, records, historians, independent interpretation and discussion of test. So the category 1 under the low will be like the test and documents only. So category 2 under the low level will be the assessment requiring independent historian. So you'll be wondering what is historian, these words, right? These words have definitions explained in detail in the CPT book in the E&M section itself. So you can go and check that one. So for the low level, which is a limited amount and complexity of data to be reviewed and analyzed, there are two categories in that. Either one of these categories should be met. Both of the categories not necessary for the low. The first category in this is test and documents. The second category is assessment requiring independent historian. So under the moderate, for the moderate, there are three categories. Moderate and extensive, these three categories are the same word by word, and the meaning is same for the moderate and extensive categories, three categories. So the first category is test, documents or independent historian, and category 2 is independent interpretation of the test, and third one discussion of management or test interpretation. So these three things, test and historian first one, independent interpretation second category, third category is discussion of the test. For data to be considered as a moderate under MDM, it should fulfill either one of these three categories. These three categories you have to check. If it's one is fulfilled, you can go for moderate. For an extensive, if it's 2 is fulfilled out of these three categories, if 2 categories are fulfilled in the documentation of the doctor, then you can consider as extensive or high. So this is how you choose the data. So as per the definition, what is an independent historian? An independent historian is an individual, example a parent, guardian, a surrogate, spouse or any witness who can provide history in addition to the history provided by the patient. So who is unable to provide a complete or reliable history. For example, the patient might have a dementia patient, or the patient has some developmental defect, or the patient has psychosis. All these, in this scenario, the patient cannot give correct history, or even if the patient is giving some history, it cannot be complete or it cannot be reliable because of the patient health condition. In this scenario, they inquire the other individual, that is called as the independent historian. It can be a parent, a guardian, a spouse or any witness. So in the case where there may be a conflict or poor communication between multiple historians and more than one historian is needed, then the independent historian requirement is met. Also when there is a conflict, like for example there are two or three historians available, who are telling something, some history, but it's not like all are not same, it's in conflict. In this scenario also we can consider that it is met. So what is not considered as an independent historian? For example, in certain cases the patient language might be a barrier to communicate with the doctor. So in that scenario there will be some translators in between, right? So if there is somebody who is translating the patient all histories to the doctors, does not include as an independent historian. Also, for example, if the patient historian, like the parent or somebody who is related to the patient, does not require to come in person, like they should not, it's not mandatory for a face-to-face conversation for the physician for that to that historian. Even if there is no face-to-face conversation, it is accepted, but it should be like the historian is the only one who is directly providing the information, like to the doctor, even through phone calls. The historian should be directly providing, not someone intermediate for the historian and the physician. It should not be calculated. So this how the MDM data is calculated. So the next one under MDM is the risk of complications, morbidity, mortality of patient or patient management. So under risk there are like several criteria. It can be classified based on prescription drug management, and also for decision for a minor or major surgery procedures, and then SDOH, significantly limiting diagnosis or treatment. So the next one is the SDOH, which is the social determinants of health, significantly limiting diagnosis or treatment. Then decision to hospitalize, and also decision to forego treatment or hospitalization. So these things should be considered when calculating the risk. So based on this, for the risk table, risk of complication or morbidity or mortality of patient management, so it is divided into minimal, low, moderate, high. So minimal risk of morbidity from additional diagnostic testing or treatment, low risk of morbidity from additional diagnostic testing or treatment, likewise moderate and high. This is how the risk table is classified. So minimal risk is the patient problem is very self-limited or very minor problem, it goes too straightforward, that is a minimal risk. For a low risk of morbidity from additional diagnostic and testing, we can consider from the two or more self-limited minor problem or only one stable. Based on that, it will be derived to a low risk. For the moderate risk of morbidity from additional diagnostic testing of treatment, for example, if the patient is given only prescription drug management, only a drug is prescribed for the condition, otherwise a doctor decides for a minor surgery or a procedure that has mild or minor risk factors. Also for decisions regarding elective major surgery without identified patient or procedure risk factors, like there will not be any risk involved and it is an elective major surgery. And also in scenarios where the patient has a diagnosis or treatment significantly limited by social determinants of health. So what is social determinants of health? The definition given by AME for social determinants of health is economic and social conditions that influence the health of people and communities. Examples may include food or housing insecurity. So if the patient has a food or housing insecurity, social or economic status or condition of the patient is influencing the health of the patient. So if the diagnosis or treatment is significantly limited by SDOH, then it will be considered as moderate. So for the moderate risk, you should be considering all these things, like either the patient has a prescription drug management, or is there any doctor has decided for a minor surgery that doesn't pose a risk factor. Also if the doctor is like deciding regarding an elective major surgery, even that will not pose any risk factor on the patient. Also for the diagnosis or treatment of significantly limited by SDOH, that is social determinants of health. In these scenarios, you will consider that as a moderate level. For the high risk of morbidity from additional diagnostic testing or treatment, example goes like drug therapy requiring intensive monitoring for toxicities. Like for example, the patient is going on a drug therapy, but still this patient that is going on a drug therapy requires an intensive monitoring because of the toxicity. The second example they have given in this is decision regarding elective major surgery with identified patient or procedure risk factors. There is a difference between moderate and high in this scenario. Like for a moderate, if the decision regarding, if the doctor has decided for an elective major surgery, there is no potential risk factor involved, then it goes for a moderate. But in this scenario, for a high one, if there is doctor has decided for an elective major surgery with identified patient or procedure risk factor, there might be a risk for the patient health because of the patient's say status or because of the procedure. If there is a risk factor involved, then it should be considered as an high level. Next one, for the decision regarding emergency major surgeries. For all the major surgeries, that is an emergency, not an elective one. What is an elective one? Elective one is the doctor will fix a date, will take time, and because it will not affect the condition or the status of the patient health. Emergency means it does not mean that it should be a major surgery. It is a quick diagnosis, and also it is a quick decision to do it immediately, because if it is prolonged, if it is made as an elective surgery, like that can be postponed for some days, it might affect the patient's health status. So, decision regarding all the emergency major surgery should be considered as high, and also decision regarding hospitalization or escalation of hospital level of care. So, if the patient has come for an OP consultation and if the doctor is deciding that this patient should be hospitalized immediately, then it should be considered as an high. Or even inside the hospital level of care, if the doctor is deciding regarding moving the patient to the next level of care because of the severity or the intensity of the patient's health status, worsening of the patient health status, it should be considered as high, major. The next one is decision not to resuscitate or to de-escalate care because of poor prognosis. So, what does it mean? Like, for example, if the patient has loss of consciousness and they decide not to revive the patient because of the poor prognosis, even if they revive, it will not be successful. And also, even if they increase the intensity of the treatment, it cannot be successful because of the condition, the prognosis of the patient. In this scenario, they will reduce the intensity, that is, a de-escalate, and they will resuscitate, that is, they will not resuscitate, that is, they will stop trying. So, in this scenario, it means the patient prognosis is very poor, and that will be considered as major, high. And the other scenario here is the parenteral control substances. So, in this, what is parenteral control substances? The patient cannot take any of the nutrients or the medications orally, it should be through the IV only. It is obvious that if the patient cannot take anything orally, it is always through the IV for the nutrition and medication, then it should be considered as a high risk. So, to clarify the risk, I will again repeat, for a risk to become a straightforward, it is a minimal risk, like the patient has a minimal problem, that is self-limited or minor problem, no need of any treatment or diagnostic testings are required because the risk is very minimal. For the low risk, it is again the patient has 2 or more self-limited minor problems, just a stable problem, chronic problems, or a stable acute uncomplicated injury or illness. In this scenario, the patient is considered as a low risk of morbidity from additional diagnostic testing or treatment. For a moderate risk of morbidity, there are some examples. For example, the doctor has prescribed some drug management, and also in scenarios when the doctor decides to do a minor surgery which will not pose a potential threat for the patient health because of the procedure or the patient status. And also, the decision regarding elective major surgery, in this scenario also you should consider, if it does not pose a threat or there is no high risk factor based on the patient health status or the procedure, then it should be considered as a moderate risk. And also, under moderate risk, we saw for the diagnosis or treatment of significantly limited by social determinants of health. If the patient economical situation and social situation is like that and the doctor cannot complete management to the patient because of this SDOH, it should be considered as moderate. That is what we saw in moderate. For the high risk, we saw some examples, like if the patient is going on a drug therapy, and also in this drug therapy the patient requires an intensive monitoring because of the toxicity. Even the controlled drug therapy might result in toxicity. So, the patient requires an intensive monitoring to avoid any risk factor. So, this falls under the high. And also, when the doctor is deciding for an elective major surgery with identified patient or procedure risk factor. So, if there is a risk factor involved even in elective surgery, that is considered as the high risk. For the decision regarding all the emergency major surgery, it is obviously high risk, and for the decision regarding the hospitalization or escalation of hospital level of care, it is considered as high risk. And when there is a decision not to resuscitate or to de-escalate care because of poor prognosis of the patient, it is considered as high risk. And if the patient has parenteral control substances only, like in this scenario, it should be considered as high risk. So, I believe the risk is clear. And if you still have any doubts in this table, you can very well put it in the comment section below. I will try to answer maximum based on the coding guidelines. For the level of MDM, that is medical decision making, it is based on problem complexity, risk and data. And for that, 2 out of 3 of these components is enough. For example, in this table, as you can see, we will see an example like the patient number of complexity of problem addressed is going for moderate, and amount and complexity of the level of data is going to moderate again, and the risk of complication or morbidity of mortality of patient management goes to low. So, in this scenario it is moderate, moderate, low. As per the guideline, 2 of the 3 components is required. So, there are 2 components, that is moderate and moderate. So, in this scenario you will choose the moderate MDM. You got my point, right? So, that is all about the 2023 E&M CPD guideline based on MDM. So, when you see the book, or if you can go to the AMA website and see the 2023 E&M guidelines, they have given a definition for all the elements of MDM that I have mentioned, like what is a problem, what does mean problem address, minimal problem, what is chronic illness with exacerbation, what is the meaning of acute complicated injury. Likewise, for the data also they have given what is analyzed, what is the meaning of test, what is the meaning of independent historian, that I explained already. And even in the risk they have mentioned what is risk, what is morbidity, what is SDOH, what and all is considered as surgery, minor, major, elective surgery, risk factors, all these things. So, these things are there already. If you want me to explain each one of these are like definitions only, it is very clear in the book. You can go through that, and if you have any doubts in that definition and description, you are not able to understand anything, you can very well ask me in the comment section below. And if you really need it, I will put a new video based on your request. So, the next one, level of service based on time guidelines, because from this year we saw in the beginning the level of service should be selected based on either one of the things. One is MDM that we covered now, the second one is the time. So, what is the time guidelines? There are only 4 things we have to focus here. So, when the time is used as a factor for reporting E&M service codes, the time defined in the service descriptors is used for selecting the appropriate level of services. If you are going to choose the time as a factor to report that E&M service code, or if the physician is choosing the time as a factor, the time that is described below the E&M code, I showed an example of an E&M code, how the E&M code will look, right. So, for example, in this scenario it is 99234 hospital inpatient or observation care. Below the time specification area you can see it requires 45 minutes. So, it is always you should check the code descriptor, what is the time limit. There is no particular time limit for each level. For each code, service level code, category codes, it will change. So, you should look into that under that appropriate code, for that appropriate level of services when you are considering time as the factor. So, the second point here is the E&M services for which these guidelines apply require a face-to-face encounter with the physician or any qualified healthcare professionals and the patient and or family or caregiver. So, there should be a face-to-face, only a face-to-face encounter should be considered for time factor. The third one is time is not a descriptive component for the emergency department level of E&M service. So, for emergency department, you should not consider time as a factor in choosing the code for emergency department. It does not apply to critical care is still based on the time only. So, when prolonged time occurs, the appropriate prolonged service codes should be reported, may be reported based on the guidelines. These prolonged time CPT code guideline I have discussed in my previous video. If you have doubt, you can go and watch that one. So, this is all about the evaluation and management E&M coding guidelines of 2023. If you have any doubt, then feel free to ask it in the comment section below, or you can email me as well in this email ID, and I will try to answer everything based on the coding guidelines. If you want any clarification in this, you can let me know. I will try to prepare a video if you want anything specifically based on the evaluation management, much more details. If you want, you can just specify that in the comment section below, and if it is needed, I will try to make it. If you found this video to be useful, please hit the like button and please share with your coding friends so they can be benefited from this. And if you are new to this channel, please subscribe and hit the notification icon so you will not miss any of my future videos. Thank you so much. This is Surya Johnson, your medical coding guide.